So, good morning, everybody. Before I start this workshop is basically for the ECG, and from ECG we'll be moving to the electrophysiology also. If somebody is interested to know how it works, how we are doing the procedures, you can stay back with for that also. Before I start, I should say what is my disclaimer regarding this cardiology, electrophysiology. So I was a person who hate three things, and over the time I start loving those things. The first hate thing was that I don't want to go for the general medicine. So when I was doing my MBBS, my wife pushed me, means would be wife that time. So she told that uh, you are intelligent guy. If you are going to take, I was going for genetical engineering, means microbiology and all those things was my interest during my MBBS second year, third year. So you are not fit for that. You should not take that type of subject. Otherwise, people will label you that you are not intelligent enough to take the medicine and general surgery or like a clinical subject. So you go for that. So I then later on start striving for general medicine, entered into general medicine. When I was doing medicine, I was more interested for the nephrology. And the reason I don't know, but I find the person who was the DM resident in the Banaras Hindu University, he inspired me a lot. He was having a very good grip of ECG. He was having good grip of echo, clinical, infection, everything he was knowing. And I came to know that he's a nephrologist, and his name was Dr. Prashant Kedelia. He worked in St. John's Medical College, Bangalore. So I got inspired with him, and I thought I will take nephrology. By the way he make a diagnosis, clinical was so sound that pulled me that I should go for the nephrology. Then again came the picture. My brother, he told me, you are not meant for the nephrology. Nephrology is meant for the people who are not able to strive for cardiology. You are an aggressive guy. People will again label you that you are not able to strive for that one, and that's why you have taken this one. So suddenly my mind changed. And during my MD time, when I was doing MD pediatric for 1 year, I was not able to make any sense about the ECG. Anything means during MBBS, ECG was given. We have marked it as ST elevation, ST depression, and all those things. And after that, we have never seen the ECG during my MBBS time. So I thought I will go for the cardiology. Anyhow, I entered in the cardiology due to my, we can say, the nudge by my brother. And when I was doing cardiology, I hate electrophysiology. And the reason is the electrophysiologists, when they will enter in the cath lab or EP lab, if you have seen or not, they will be silently doing their work. Somebody will be saying this one, that one, and their language will be out of the book. Out of the book means whatever you are reading in the book, it will not be there. Jump is there, this is there, that is there. Usually, when we enter in the interventional cardiology, we will be having a lot of informations before we enter it. Okay, angiography, where is the block, what are the vessels, all those things. The language of the book and the language of the cath lab will be almost same, not much different. Means something you have learned and same thing you are going to see inside the cath lab. And there is very basic things. Means blood is flowing, where is the block, all those things very easy to identify. But when you are going the EP, it is totally different. Means it is like for North Indian learning the South Indian language. So when you have learned everything and we are entering in there and they are speaking something which you will not be able to handle, what they are saying, jump they are saying, bus they are, and those language will not be in the books. And that is one of the reason a lot of people don't want to pursue in the electrophysiology. And the reason is patience. You have to have a lot of patience for first learning and then later on getting that grip of the subject that you can practice. Most of the cases are elective cases. Patient will never directly reach to you. A lot of stalwart are sitting in the city or in and around, and when the patient is stable, they will reach. Here we are having in intervention cardiology, we are having opportunity to directly intervene. Patient is having MI, he will not go to the other cell, so you can intervene. And whoever is available, that's why intervention cardiology you will be able to get the cases over the time. But EP, you have to build your own image or own stretcher to get a one case. So these are big hardship, and nobody want to do a procedure of 1.5 to 2 lakhs after getting at least 3 to 4 years of EP. And why I brought that EP subject, that why people are not interested, and the reason is the language. And the language of EP is in the cath lab is totally different, and that's why I wrote a book also that I think you people are maybe knowing ECG to ablation. That was basically meant that people who are not able to understand the language, the raw language which is being used in the EP lab, they should not get frustrated at least for the first 6 months. So they will understand what they are saying. It is written in the same language, and not the what you call. If you go in the court of law, what they will be speaking, and when they will be coming out of the court of law, they will be speaking the different. The crux is same, but the way of presentation is different. Same thing is for the book versus the practice in the EP. So this was my third what you call hate, which I start loving, and later on I find that EP is one of the important subject for everybody. If they want to really get the gist of cardiology, more is in the electrophysiology than in the. It should we should not see as a ECG. ECG is one of the things which give a lot of information regarding the cardiac health. You can decide a lot of things. So not wasting much time for that. So everybody is there. Welcome you all. And this is a ECG workshop. After that, we will be going for the EP workshop. So something already I may have presented to you. So don't get bored by those things. If you are knowing, it's okay. But certainly I will give a new insight for whatever things we have discussed. And I am keeping in this record so that if anybody who has missed it also, they can revise or they can share with their colleagues if they are not able to come due to their duty. Or so ECG 360 is the product what I have crafted by myself, and it is basically meant that if you are approaching ECG, how to go ahead. This is the foundation on for which I work, and basically it is for the arrhythmia what you call awareness and how to approach and education. And the rule of thumb in the ECG approach is like X-ray and ECG both are having a systematic approach. You have to go either from, if you are seeing the X-ray, you will be saying that okay, you should go from outside to inside or inside to outside. The approach should be remain the same. The same systematic approach is needed for ECG. And the important thing, whenever we are reading the ECG, we should be knowing what the clinical background. If you are not knowing, you will not be able to make the interpretation, and certainly you will not reach the diagnosis and the treatment protocol if you are not knowing those things. Means what drug you have to decide, whether the differential will be top one, this first one will be particular diagnosis versus other. How you are going to decide, it is totally dependent on the clinical scenario. A chest pain patient is coming who is 18 years versus chest pain patient who is having a typical complaint and who is coming at 50 years with and without risk factor. It makes a difference. Same thing, age, gender, and we have to know what is abnormal, normal, and normal, abnormal. So there the main difference comes how well you read about the ECG on ECG, because when we read the ECG in the books, they will be giving all the classical scenarios. They will be seeing the sawtooth appearance, and they will show you also, you will grab in the mind also. But when you come on the ECG, we will say where is the sawtooth appearance and where to see. So where to see and when to see and how to see. All these three things will come when you start checking the ECG. When you are getting the ECG and you are going in a systematic way, where to see. So where to see is never written in the book. It will be writing classical short tooth appearance. You will read, you will go and attempt the question, everything will be fine. But when you come on the ECG, sometime you will be missing that it is there, I was not able to see. So those points we are going to touch upon. So rate, rhythm, axis, interval, P wave, duration, amplitude. QRS, duration, amplitude, R wave, progression, ST segment, T waves, and finally the 10th point is the abnormal pathological Q wave. So pathological Q wave, delta, epsilon, epsilon. These are the things which we will be touching one by one. So regarding rate, rhythm, and axis. Most of the time, if you are taking the ECG, you will be getting all this information given in the, and most of the time it is correct because the ECG tool by which we are measuring is well versed with the axis as well as R wave, rhythm as well as rate. If the properly taken ECG, it will give all the information. Intervals also you will be getting P wave, duration, but Here what interpretation makes you above the ECG machine, that what interpretation it is giving, how you are interpreting in background of the patient's history. So this five information is already there, not much needed, but how to interpret if this is not here, that we will be discussing. Duration, amplitude, R wave progression, ST segment. ST segment I have marked with the red, and the reason is most of the time everybody gets stuck up, even in the cath lab to the emergency. ST elevation, depression, and people will be confused. And they are not to say confused, they are totally want all the result to be based on only one thing, ST segment. Whether we are missing some more things or more information is needed or not, that should not. So yes, ST segments deviations are really important parameters to, like a triage. ST elevation is coming, don't waste much time if the patient clinical scenario is fitting in that one. We start with the bottom. So whenever you are reading the ECG, start from the bottom. The first thing is what is the what you call speed of the ECG. So mostly it is 25, but when you are going in the examination, they will give a ECG which look like to be bradycardia, and you have not seen that on the bottom it is 50. So always and always try to see the bottom line. Second, the standardization. So 10 millimeter versus 1 millivolt is the normal standardization. Third is this is called damping, under damping, over damping. So most of the time now in the new ECG machine, this is not that much important. And fourth is the frequency. So what are the frequency on which it has been measured? So it's not say frequency, it's called filter setting of the device. So sometimes you will be seeing a lot of changes will be happening from one ECG machine to other ECG machine, or even from the one center to other center. And if you want to really make the difference, whether it is properly taken or not, or you always try to see these three information. One is speed, second is standardization, and third and most important, what is the frequency on what is the filter setting. So you will see the filter setting in that patient may be different. So filter setting is a very crucial thing when the undulations is happening. You are getting ST elevation outside ECG, and when the patient is coming, you are not getting the ST elevation. And the difference will be only and only that the filter setting was not proper, or the filter setting on which it was coming ST elevation was not the same what we are seeing. This become more important when we are speed regarding. I will not go in the detail, but very I think most of the time it is we can say the RR interval you have to see, divide by 300 by 1500. Small boxes 1500, large boxes 300. Divide it, you will get the values. And regarding the under damping, over damping, if you can see, this is a proper damping. There is a clear cut. There is no what you call undulation going up, and here there is no cut of the part of this one. The square is exactly. So this is we can say properly taken. First is the properly taken normal without damping, and standardization we do means sometimes the ECG you will be seeing the baby's ECG, or you can say the young person ECG. The QRS will be merging one over other. Means V2, V3, you will be seeing the R wave and S wave will be going up. So in that scenario, what you are going to do? So you have to change the standardization. So normally the standardization, what we are keeping double versus half. So 10 millimeter is equal to 1 millivolt. We are going to say 20 millimeter, or we can change into the 5 depending upon how the QRSs are thing. So that is called standardization changes. And speed, anyhow, I discussed you. Filter setting, that when you are getting ST elevation, try to see what filter setting is happening. So there are two filter setting normally we will be seeing, 0.05 versus 0.5. Upper is usually remains same most of the time, 150 or 125, whatever is there. But if the lower filter setting has been changed from 0.5 to 0.05 to 5, the ST elevation will start happening. And this is the common setting when you are keeping the monitors in the ICCU or emergency. You will be seeing the ST elevation is coming. When you are taking the ECG, you are not getting. And the reason is the filter setting of your monitor is 0.5, while that of the ECG machine, what you are using is 0.05. We call as a high pass filter. The any frequency above 0.05 is going to be captured. Here, any information more than frequency more than 0.5 is going to be captured. So what will happen? It is going to elevate some of the ST segment information, and it will going to be ST elevation. So on monitor, never totally rely your ST elevation and depression findings. It may be misleading. Okay. And the reason is when the respiration rate are high, we want that the frequency should not change the undulation of the patient. So most of the patient in the ICCUs or in emergency, they will be having a high respiratory rate. So respiratory rate as well as your heart rate should be in having frequency. It should not go and cross each other. And that's why the frequency is kept on the higher. The high pass filter is on the higher side. Is it clear now? So we are increasing the filter setting from 0.05 to 5, so that undulation means the ECG should not start undulating it. But at the same time, it will change the ST elevations. Sometimes ST elevation may be there. Okay. So this is the what I was saying. The undulation is happening. You will be seeing, and the time you're changing the filter setting, that time it will get normalized. So 0.05 you do 0.5, this undulation will go. Muscle tremors, all those things is not going to be captured. And this is the, if this type of noise is coming, we call as a 60 in the India, and if you are going the European countries, it will be 50 cycle noise is there in the ECG. Okay. Now coming to rate. So in EP, we never say 60 beats per minute. We will be saying 1,000. Cycle length we usually calculate, and cycle length calculation is 60,000 by heart rate. Whatever the heart rate is, you just divide it. If it is 100, we'll say 1,000. And this calculation, I think just now I discussed with you. So small boxes versus large boxes. So 150 small boxes, 30 large boxes, it is equal to 6 seconds. And this is normally whatever you are taking the ECG. Most of the time we are taking a slice of 6 seconds, and we are going to multiply by 10. You will be getting the heart rate normally. So the easy way to know the numbers, you just see the where the QRS is falling on the main line, means what you call this you are getting is large man, and the next QRS where it is falling. If it is falling on the next, it is 300, 150, 100, and 75. It is a very easy way to identify what is the heart rate. You are not to calculate. If you are the first QRS is here, next QRS falls here, it will be 300 heart rate. If it is falling on this is 300, 150 heart rate, 100, 75, 60, and then 50. Like that it goes. So this is the pattern what I was saying. If you want to see in the ECG, you can say the rate. Just see what is going on. So if the 6 box is the distance between the two QRSs, the rate will be around 50. And the rule is less than 3, more than 5 are abnormal. Means the rate is less than 3 is means patient is having tachycardia. More than 100, and more than 5 boxes, it is bradycardia, means less than 60. Coming to the second, sinus rhythm. Means when we are saying sinus, means sinus node is driving the rhythm of the heart. And how it is possible, how to identify? So sinus is on the top right side of the heart. So excess of the P, QRS, P at least will be the driving force, and P will be positive in lead 1 and lead 2. So if you are getting P followed by QRS, means P is married with QRS, and at the same time, the rhythm should be regular. And third thing will be there, that P should be upright in lead 1 and lead 2. Okay. If you are able to drive the axis of the P wave, it will be between 40 to 60 degree. So axis part when we will be seeing, so you have to see the first P followed by QRS. PR interval is almost fixed, means it is the conduction is going through that one. And third thing, you have to show that P is upright in lead 1 and lead 2. Okay. Lead 1, lead 2 means 0 and 60 degree, both are positive, means it is in the same quadrant, lower quadrant. If you are not getting it, let me know. Okay. And this thing is very easy to identify. If you are seeing the P wave which is positive in the lead 2 and negative in AVR, means the current is flowing like this one. It is going from up to down. So sinus is here and it is going down. So like that it will be. Okay. So most of the time the electrical axis will be in this line. You are seeing this one? It is coming, yeah. Location of lead taking. A lot of people say think about lead to where we are going to keep lead one, lead two. So all stories in fourth intercostal space. Sometimes people say second intercostal space, but it is not. 4 and 5. These are two intercostal spaces. We are utilizing it. So, and there is a color coding. It is basically for the person who are taking the ECG. I will not go in detail. Coming to the axis. So axis of any means P, Q, R, S, T. All we can decide it. We have to use the limb leads to identify it. And making it simple, you have to see only two leads, lead 1 and lead AVF. Okay. If both are positive, it is normal. If both are negative, it is called extreme right axis or indeterminate axis. And if it is lead 1 is positive, AVF is negative, the left axis deviation. If it is AVF is positive and lead 1 is negative, it is right axis deviation. So it is one of the most simplified way. Either if you are seeing the P wave, if you are seeing the QRS, you are seeing the T. Just concentrate two leads, 1 and AVF. Both positive, negative. Means P wave is also positive in both the things, with axis is normal. And making, if you really want to know what is the exact axis, most of the time the ECG machine will be giving how it is calculating. The calculation method is this one. So you have to see what is the positive and negative. So here you can see -1 and +5. It is +4. Okay. And negative wave is how much it is? It is around -1 here. So it is altogether the lead one. If you are going to mean calculation, it is 4 here, and in lead AVF it is 9. So 9 in the AVF, 4 in the lead one. Line of intersection is the axis. Is it clear now? So whenever you are seeing P wave 2 and 1, you can immediately line of cross section. You can just make it, and you will get the axis. More toward AVF means AVF is more positive. AV and lead 1 is less positive, means axis towards the foot side. But it has become negative. Lead 1 has become negative. AVF has become positive. It means right axis deviation. Is it simple? Okay. Regarding axis, P wave axis, QRS, T, all axis will be going line in line. And the important rule that we should know, P is depolarization, QRS is depolarization, and T is repolarization, but it is also in the same direction. Are you understanding? You will be seeing P is also positive, QRS is also, T is also positive. But why the T is positive? The repolarization and depolarization of the ventricle are totally different. So when the P wave, when the QRS is going, it is inside to outside. That is called depolarization is happening. But the repolarization is opposite. The things which has depolarized first will be the last to be getting repolarized. That's why it is positive. Is it clear? So repolarization will be always, these all three waves are hand to hand, always in the same direction, at least in the limb leads. Okay. Chest lead is a totally different story. I will later on go. So, and this angle QRST wave angle means QRS and T both will be within 40 to 60 degree. Around 40 degrees is the normally axis there between these two waves. Coming to the intervals, so RR interval you have to measure and you will get the heart rate. P wave duration, most of the time it is 80 millisecond. PR interval is 120 to 200. These are the intervals that you have to remember. There's no question queries regarding the QRS is 100 and QT is around 440 and 460. 440 for the males and 460 for the females. So if you are taking the ECG, just see the what you call intervals and decide what exactly the cause can be. So like if P wave duration is increasing or amplitude is increasing, what can be the cause? If PR interval is crossing 200 or less than 120, what is the cause? So you have to start scratching your mind. The intervals are changing. So what can be the causes? But before going, P wave duration from where to where we have to measure. Starting from the P and the end of the P is called P. P duration, and PR interval start from starting of P to the start of the QRS. Either it will be Q or RR. And PR segment start from end of the P and starting of the QRS. So PR segment is different, PQ, and PR interval is different. Segment versus interval is different. Okay. Regarding ST and TP, all those things will again discuss regarding that. And rule of three boxes. So all the chamber enlargements, when we are thinking about left atrium, means P is giving the information with atrium, and you have to decide whether the left atrial enlargement is there or not, right atrial enlargement is there or not, biatrial enlargement is there or not. Then you have to just focus on only thing, and use the rule of three. Three boxes up or three boxes wide. Three boxes wide, left atrial enlargement. Three boxes up means amplitude, right atrial enlargement. Okay? Is it to identify? Huh? Pardon? Yeah. Is it clear? Yeah. So in this you can see this is called amplitude and this is called duration. So when the duration is increasing, with left atrial enlargement is there. If the amplitude is increasing, right atrial enlargement is happening. And where to see? This is the important question. Lead to. Why lead to? Why lead to? The highest current will be in the lead 2 only, because when the current is flowing, when the sinus rhythm we have labeled, the current will be flowing from the up to down, and P wave axis, QRS axis, even T wave axis, all are aligned to the between 40 to 60 degree. And 40 to 60 degree, which lead is aligned? It is lead 2. So in the lead 2, you are going to get the P wave duration and amplitude you have to see. But sometime you are not going to get the proper P wave in the lead 2. So where to see the P wave next? V1. V1, why we are seeing V1 lead? So V1, one is the lead 2, I'm saying about not the amplitude. Sometimes you are not getting the proper P wave. Immediately start focusing only one lead, V1 lead. V1 lead is on the right side and it is very near to the sinus. Okay. So if you are not getting a P wave in that also, then you have to think either you are dealing with atrial fibrillation or it may be a junction rhythm, either of the things. So these two leads you have to always see, lead 2 and V1. And if you have to apply the rule of three boxes here and there, you have to apply for lead 2 only. When you are going for V1 lead, the application is totally different. Here the things is if you are getting one box, it is right atrial enlargement, and if the lower box means it is usually biphasic. V1 is having biphasic P wave, small p, then again inverted. When the inverted part is getting broader and deeper, we call as a Morris index. So Morris index will be positive, and the patient will say that left atrial enlargement is there. So this is a left atrial reflection, and this is a right atrial reflection. So if the first part is getting broader and amplitude is increasing, crossing one box, we say that is a right atrial enlargement. Okay. If both are there, we can say biatrial enlargement also. Okay. So now coming to the QRS. So P wave is over. We have gone the sinus rhythm. We know that the sinus rhythm, the P wave amplitude is normal, means the chambers are not involved. If P wave amplitude is increased, the right atrial enlargement. If duration is increased, left atrial enlargement. Now we are going to see the health of ventricles. And we are not using enlargement. Now we are at abnormality, left atrial abnormality, not left atrial enlargement. Why? If people are not asking why. Previously, we are using left atrial enlargement. Now we are saying left atrial abnormality. Because whenever the conduction, these are all conduction, na? So when chambers are enlarging, it can happen, but it is possible that there may be conduction abnormality. The conduction between the left atrial and right atrial, sorry, right atrial to left atrial, which happened to Bakeman bundle. That is the fastest conducting bundle, which is situated just on the roof of the atrium. So SA node, and it will immediately start conducting to the left atrium through fast. That's why both the things will be, both the P waves will be merged. So when it is taking time, left atrial enlargement will mean the left atrium is increasing, or the backbone bundle is not functioning properly, means it is not conducting fast. The P wave duration will increase. So it can be a abnormality of chamber dilatation or conduction. That's why we use abnormality, not previously we are saying enlargement. So left atrial abnormality, LAA, right atrial abnormality, RAA. Okay. Now coming to the QRS complexes. So QRS complex is the sixth component of the our ECG analysis, and here the first question we have to see whether it is a broad versus narrow, whether we are saying in the sinus, and if it is a sinus, whether it is a tachy versus brady, and if it is a broad, then we have to apply some other rules. So QRS identify if it is narrow, then some rules are applicable. If it become broad, some rules are not applicable. Okay. So when it is narrow, then you are going to apply the voltage criteria for ventricular hypertrophy. Okay. Right ventricular hypertrophy, left ventricular hypertrophy. Somebody has given a LVV and they are asking what is LVH. LVH is there or not. You can't comment. You said I am not knowing. It is not applicable. So first criteria when you are saying right ventricular hypertrophy, left ventricular hypertrophy, you have to label that QRS is less than 120 milliseconds. And after that you start using the criteria. And then there are criteria for LVH, RVH, biventricular hypertrophy, whatever the criteria. If it is a broad, then we have to give the reasoning why it is broad. So the first question will be, it is a bundle branch block or not? It is a paced rhythm or not? Or it is a VT or not? Means these are, the rhythm is coming from ventricle, or it is a paced rhythm, or it may be a bundle, means the bundles from the RBB, LBB are getting diseased. So these are the three important causes of broad QRS. So complexes, when they will be narrow and when will be broad, that we should be very clear. Because when you are saying narrow, means the rhythm is coming from node and above. Any rhythm which is coming below the node will be broad. Means his bundle, bundle branch, ventricle, Purkinje's, kahin se bhi aayega, it will be always and always broad. But a narrow rhythm can, means anything which is above the node can become broader depending upon the health of the bundles. This concept means all the, what we call as all broad QRS are all broad QRS are VT. Means all VT are broad QRS, but all broad QRS are not VT. So concept is anything that is supraventricular, means when the node and above is having a rhythm problem, that will be narrow, broad, both is possible. Anything, if it is narrow, means the QRS is narrow, means it is coming from the above the node, that is clear. But if it is becoming broad, doesn't rule out that above the node is not the possibility. The reason is the bundles may be diseased. So in that scenario, the broadness will be coming. But narrow, when you are saying, forget about that, you are not dealing with the number one, VT, number two, bundle branch block. These are not the part of the story. It is totally and totally healthy bundles with node or above conduction. Okay. So this is the thing just I wanted to impress here. Sorry. So how it will be going. Okay, sorry. So coming to the criterias are important, that some criteria you people should be. So when we are using the LVH criteria, so there are chest lead criteria, limb lead criteria, and both, means both are been applicable. So first, chest lead, which is most commonly used. You should see V5, V6, the R wave and S wave in V1, and add it. If it is more than 35 in a patient who are more than 35-year-old, because all this criteria has been meant from the studies which has been done in the 35-year-old persons. So he should be at least 35-year-old, and the if you are adding R wave of V5, V5 or V6 with S wave of V1, it should be more than 35. Second is, if you want to see only one lead, and that is one limb lead, you can just go to the AVL and see the what is the amplitude. If it is crossing 11 millimeter, again it is a uh, LVH. And third is the coronal voltage criteria. It uses two S wave of V2 and R wave of V5. If it these two things, sorry, this is not. Let me. R wave of AVL and S wave of V3 means two leads you are using. That is male and female. It is different. For male, if it is more than 28, and female it is more than 20, is taken as a. But most commonly used is the Sokolov-Lyon index, and this is coronal voltage criteria. These two criteria are commonly used. If you have to see one ECG and you have to say that patient is having LVH, ECG wise, and it is V5, V6, how you are going to say? Any point on which you can say it is LVH or it is not LVH?
V5 more than V6.
Hmm?
V5 more than V6. It is what
V5 more than
V6.
or V6 more than V5?
V5 more than.
Hmm? So mostly the V5 is the last lead in which the highest current you are getting. But anytime if it is going, V6 is crossing it. It start reducing after V5. So V5 mostly the highest you are getting. Anytime if you are getting V6 more than V5, or T wave inversions is happening, or ST depression is happening. So these are indirect marker that patient is having LVH. So highest current is I think V4. V4 followed by V5, and V6 it start reducing it. Now coming to RVH. RVH is the right axis deviation. If you are getting any time without any reason. Without any reason means if a baby is there who is 7 year, 8 year, 7 month or 6 month, in that the right side is usually dominating. Slowly it start changing over time. So if you are without any reason, if you are getting right axis deviation, it is a mark of RVH, or if you are getting a dominant R wave in V1 or dominant S wave in V5, V6 is a mark of RVH. Simple. And this all rule where you are applying when the QRS is less than 120. Okay. So RBB is there. Don't try to apply this rule. May be applicable, but it is not as a criteria. You have to show right axis deviation. You have to show V5, lead V1 R wave is more than S wave or more than 5 millimeter or 7 millimeter R wave will be there in this one. So this is regarding the RVH. Second is the same thing what I was saying here. It is very easy. QRS is narrow and dominant. So you can say this is RVH. Here, what is happening? Second, one of the criteria is applicable here. What is that? I think, let me make it. Here, the second criteria. This is the second criteria, what I am saying. This is the first criteria. Right axis. You can see axis is 2, 3 AVF positive, AVL negative, and this one. So it is right axis deviation. So right axis deviation without any reason means RVH is there, even though you are not getting a R wave, dominant R wave here in the lead V1. So right axis deviation is one of the cause. And third is if you are getting a S wave here. So S wave if you are getting, which is more than the R wave in V5, V6 lead, it is again the mark of RVH. So where you have to see for RVH, number one, lead V1. If it is totally positive, okay. If you are not getting C V5, V6, if the S wave is more than R wave, again it is. And third, if the axis is towards the foot, means your lead 1 is almost negative and lead AVF is almost positive. AVF, no? Yeah, AVS is positive, means it is the right axis deviation. Okay, sorry. So this part is over, this is over. Here what is happening? I think this is the same, no? चल. Now the second question arises when the narrow was there, its rules are different. You have to comment regarding RVH, LVH, or no hypertrophy. Third comes the second comes the broad versus or wide QRS, whatever you are using, and then we have to give two comments at least: RVV versus LVV, right bundle branch block or left bundle branch block. And IVCD means if you are not able to use either of these rules, means sometimes chest lead is showing LBV and limb lead is showing RBV, you again will say use the word IVCD, means it is not fulfilling the proper criteria of LBV and RBV, then we say intraventricular conduction disease. Neither it is on the north pole nor in the right pole. It is in between. It is showing the features of either of the things dominantly. Then we say IVCD, intraventricular conduction defect. Means the conduction system is having the character of both the bundles somewhere. So intermixing of the. So for time being, just forget about it. IVCD. You just see whether it is LBV or RBV. If the patient is in sinus, you have to give a comment. Yes, patient is having QRS more than 120. Immediately you have to say it is a LBV or RBV. If you are not able to make any conclusion, you can say IVCD. Is it clear? So wide QRS, first you have to see the sinus, and very easy to identify the where to concentrate, lead V1. So all the LBB, RBB, the criteria where to apply it, it is in the chest leads. And the two leads which we have to remember, lead V1 and V6. Means broadening QRS, immediately your mind should start seeing where to go and label it. So go for V1, you are seeing, okay, V1 we are getting what you call this is a classical pattern, VRSR. So if you are getting RSR pattern, until proved otherwise, RBB. Sometimes you will be having excess here and there, then you have to make further. That's why I'm saying getting one finding, you can think about the bundle branch block is there, but additional information is there to make the disease diagnosis of disease a totally different ball game. So first make the conclusion, okay, RBB is there, and if you are not able to see the V1 or V1 has not been taken properly, you can go in the V6 lead. An important finding of right bundle will be slurring of the S wave. So this is called slurring of the S wave. It will be present. So when we the slurring of S wave, you can think about the patient is having uh, what you call right bundle branch block. And first sign of RBB is what is? In a normal person, he is coming to you, and after 5 years, he's again coming to you. Can you identify he's going to develop right bundle branch block? It can be. If you start seeing the progressively every 2 years, 3 years, and over the time he has come 20 years when he is having right bundle branch block, classical, and you can diagnose, okay, RSR pattern is there. Because before RSR pattern, one important finding happened. V1 to V3, the S wave usually progressively increases, and after that it start depressing, start reducing it. So any loss of S wave in V1 to V3 progressive over the years is the first finding of right bundle branch block. Okay, something it is out of box. I am just discussing, means छोटा बच्चा बड़ा होता है तो हम लोग directly we are seeing, okay, he is now adult. We have not seen the in between what is happening. So if you want what is happening, V1 lead, V2 lead, V3. These are three leads in which you can indirectly get information that he is going to develop the right bundle branch. And what is the first finding? Loss of S wave in V1 to V1 to V3 leads. Progressively it will reduce, and later on it will convert into the RSR pattern. And if you are not able to see this pattern in the V1, you go directly in the V6, see the slurring of the S wave. This is a mark of right RBB. For the LBB, again, you have to see the same leads, V1 and V6. If it is totally positive, it is totally negative. Sorry, it is totally negative and totally positive, left bundle. Simple. But what happens sometimes, this classical pattern you may not be getting, and again you will be confused whether it is LBB or not. So broadening of QRS, number one, you have to decide RBB, LBB. This comment you have to give. LBB, where to see? The best lead is to see V6. If it is totally negative, labeled. If you are not able to see the V6 lead, you go into the lead 1 and AVL. Okay, so these two are called lateral leads. So whenever they are a broadening without any reason, without any QRS is crossing, and it is totally positive, then we are saying it is LVV. So LVV, RVV is not a difficult diagnosis. You have to see where to concentrate, and it is within the chest lead. V1 will be totally negative, V6 will be totally positive. Sometimes this word we use M pattern and W pattern. It is classical, but it may not be possible in all the cases. Sometimes you will be getting. And here I was showing it, you can see it is, yeah. So here V5, V6, you are getting V6, you are getting a positive. Is it clear here? Clear cut pattern is there, and you can see this is a LVB. Just QRS wide, you gone on V6 broad. But when you are coming here, what you are getting here? Not the pattern, M pattern or broadening. Broadening is there, but you are not getting the pattern of M, or you can say the this pattern here. Then you, where you have to jump, you have to jump to AVL or lead one. Okay. Even if you want to get a classical pattern of M in the V5 or V6, you have to go more posteriorly. So heart, when it dilates, the V5, V6, the chambers has gone posteriorly. So this pattern you may get when you are taking V7, V8. Is it clear? So chest lead sometime may not be able to get the classical LBB pattern. If you are not getting a classical LBB pattern in the chest lead, jump to your V1, lead 1 and AVL. So this will certainly give you all the information, because these are bipolar leads, and bipolar leads will be not having any orientation issues. So I have not gone in that angle. There again, you will get unipolar versus unipolar means at that location what is the current. Bipolar, we are just subtracting the two leads and making the final whatever the flow of the current, direction of the current. So first sign of RBB was loss of S wave, and first sign of first sign of left bundle branch is, huh? Huh? सब लोग पढ़ लिया है लगता है. It's okay. So the first sign of LBB is the loss of Q wave in the lateral leads. Lateral leads means lead 1, AVL, V5, V6 will be having a small Q wave. The time hypertrophy will be increasing, like hypertrophic card will become more prominent. And the first sign of bundle branch will be the initial current which happened from left to right, which is responsible for the first R wave in the V1 and Q wave in V6 lead will be disappearing. So the time the pressures are increasing in the chambers, it will impact on the conduction, and the first current will be going, the R wave in the V1, Q wave in the V5, V6 leads will be disappearing. Later on, we will start broadening, and then you will getting the M pattern. So this is the evolution of the node. Now we are coming to the climax, ST. All the cardiologists, everybody, emergency, sir, ST elevation is there. What to do next? So ST segment, where to see? I think this is the important concept, because most of the time people fail to identify, and there we are discussing three segments. Segments are different, intervals are different. So first segment is PR segment, second is ST segment, third is TP segment. And whenever we are seeing the ST elevations, it is in reference to which segment? Yes. So we should not miss the equator. North and south is going to be decided by the equator. The same thing, the ST elevations, when we are deciding the TP segment is the true isoelectric segment. It is like the equator of the heart. So whenever you are going to decide, you just always try to concentrate the TP segment, and from the TP segment you have to identify. The second important information is ST elevation is there, how much ST elevation is there, and we use the word consecutive leads. Consecutive lead means 2, 3 AVF is inferior lead, 1 and AVL is the consecutive lead, means any change in lead 1 should also be means the ST elevation should also be present in the other second lead, means consecutive. After 1 it should be 2. So like that, if it is ST elevation you are getting in the 2, immediately you should start seeing the lead 3 and AVF. If all three are there, inferior valve MI. Similarly, if the ST elevation is coming in lead 1, and you are not getting any elevation either in the lateral, this is also lateral, and here V5, V6, then you should be complacent. Okay, it may be initial changes. We have to wait for a time, repeat the ECG within 15 to 20 minutes or 30 minutes and see whether it is similar changes is there or not. So some elevations may be baseline in some patients, and that's why your baseline ECG should be the way to identify whether it is a new change or is the old changes which is present in the previously. So old ECGs are very, very vital for ischemic patient, arrhythmia patients. And that's why if make sure that everybody, means in the family also, they should have their own ECG at whenever possible. At least at the age of 30, you all should have your own ECG. You should be knowing what baseline abnormality you are having. I am having a baseline abnormality, my ECG will be showing inferior MI. If I am going for the LIC checkup, they will immediately say go for angiography and come back. But I am not having any MI, but my ECG changes are of MI. That's why baseline ECG is very, very vital. And coronary anatomy, you have to tell which block it is, because depending upon anterior versus inferior versus right with and without involvement of posterior, the whole treatment protocol, since you are coming from the emergency department and general medicine, so when anterior is there, it is a totally a different beast, or you can say the approach of MI will be more aggressive and the behavior will be totally different. The sympathetic drive will be high, heart rate will be high, and the area of territory of ischemia will be a bit higher depending on where the artery is blocked. The ST elevation will be from V1 to V6 lead, either of the things. So a question for you people who are from general medicine: ST elevation from V1 to V6 versus ST elevation in V4 to V6, which is dangerous? Hmm? Which is dangerous or which is more ischemic? Go and read it. I will not inform. There is always difference. Sometimes we say more ST elevation, more ischemia, but it is not applicable everywhere. So elevation where it is happening, and depending upon that, we have to finalize the which artery we are going to touch, which artery has to be engaged first. Like that, those information will be vital for a person who where the balloon to time is very vital. Patient is coming late, chest pain. So inferior, you know that right, we have to infer. But sometimes inferior can be due to the LCX also. So how to decide LCX versus RCA? So those information, it is not worth for the discussion in here, but you go and read it. One or two points are there that it need to be there. But yes, two, three things it is important. If ST elevation is coming in the less lead involving, less lead means V1 to V3 leads is coming, no other lead, it is more ischemic. Provided it is involved with the AVR ST elevation also. AVR. Usually AVR ST elevation is not been mostly seen, but if you are getting ST elevation in V1 and AVR, both are nearly, if you can see, both are nearby. These two leads, always try to concentrate it. V1 and AVR ST elevations are coming. It is very dangerous. This patient can collapse anytime. Rest of the leads, you are not getting that much ST elevation, and the reason is it happen in two important conditions. Number one, patient is having left main blocks, or patient is having triple vessel disease. Already vessels are enclosed, and the ST elevation, chest pain, some giddiness history he has already given, means VTVF has happened due to the a lot of ischemia. So even one or two ST elevations are there, and you have seen V1 also, we have seen V2 also, and again you are seeing AVR. Be careful, prompt the system, make the defibrillator or CPR, all these things to be on the fast pace. You should not take a chance. But the same thing is happening with the 2-3 AVF. You will be complacent. Okay, the patient, even the blood pressure is low, put a saline, because the patient is having right ventricular infarct also. So right ventricular infarct, you have to go and see the 3-4 right side leads and decide it. So this is regarding the ST elevations. So always more is not dangerous. Sometimes it will be benign also. How much ST elevation we have to take it? First is consecutive. After one, lead number two should be like consecutive. These all are consecutive. 2, 3 AVF are consecutive lead. 1 and AVR are consecutive lead. 1 AVL, V5, V6 are consecutive lead. One lead, immediately you have to see back and front. Is it clear? Back and front means if you are getting V3, you have to see V2 also and we have to see V4 also. So when you are seeing the ST elevation, never be complacent with one lead and forget about it. Sir, ST elevation. No. ST elevation, when you are seeing, you should be alert that you are giving information of a cardiac emergency. So you have to be confirmed that you are dealing a ST elevation MI, and what you have to see, V3 lead is elevated. Now we are going to see V4 and V2. Both are having ST elevations. You are 3 leads showing ST elevation. 2 leads is more than enough, but 3 leads you have shown, and you are now clear that chest pain is there, risk factors is there, and elevations are there. Okay. Second thing, what you have to do it, how much elevations is there. So when ST elevation is happening, it will not be uniform. Okay, because heart is having different location, will be having different ischemia. Is it clear? So when you are getting ST elevation of 5 millimeter in V5, 4 millimeter may be in the V4, and more will be in the V6 also. So it will be always a graded differences. Sometimes it may be equal, but mostly there is a difference in the different leads. Okay, so V1 to V6 plus 1 and AVL, if all we call it extensive anti-AVL MI, means a lot of ischemia is there, and 2 3 AVL we say inferior, 1 V1 to V3 anteroseptal, V4 to V6 anterolateral, and if it is only in the AVL lead or lead 1, we can lateral wall MI. Okay. Okay. So whenever elevation story is coming, the one important thing that we should remember, that patient may be having pericarditis also. So how to differentiate? First is generalized. You will be getting an equal ST elevation in all the lead except AVR and V1. Why? Hmm? So these two leads are opposite. Na? V1 take the current of the right side, and AVR again opposite direction of the this. So you will be getting not getting all the classical elevations, because here the current of injury on the pericardial surface. So it will be showing some elevations everywhere, but this is the posterior. It will not be showing the elevations. So V1 and AVR will not showing the elevation. And the second important findings is concave ST elevations. Convex versus concave. This important concept is important that we should remember. Convex means the what you are seeing here, elevation, and after that there is a T wave inversion has happened. And this happen in only one condition, that is called myocardial infarction. Okay. So ST elevation can happen in inflammation also, it can happen in ischemia also. Both the condition can happen. But whenever it is happening in inflammation like itis, myocarditis, or pericarditis, it will be followed by coming down. ST elevation gone up, ST elevation will come down, and then T wave inversion. Is it clear now? In inflammation, elevation will can be there, but T wave will never try to get inverted when it is elevated. Clear? Nepsan mein. So ST elevation, whenever it is happening, it is important that we have to see the T wave behavior. Two things should be seen always. One is ST elevation, second is T wave, whether it's positive or negative. So elevation followed by T wave inversion in the same sitting means elevation is also having T wave inverted. There is only one condition, that is myocardial infarction. Whenever the ST elevation is happening, ischemia can be there, itis means inflammation either in the pericardium or myocarditis can be there. Okay, but T wave will never invert unless the ST has come to the normal. Clear? So inflammation, pericarditis, myocarditis, elevations will be there. T wave will be positive. T wave has normalized. It is totally same T wave. Later on, means like a patient who is coming with a pericarditis. Just think about it. Today is presented ST elevation. You are getting V4 to V6, all ST elevation. 2, 3 AVF, again ST elevation. There is no territory in this one. So pericarditis, you are thinking. After 2 days, when he is coming, T wave has inverted and ST elevation is still there. What is your diagnosis? In fact, you may have missed because of the presentation, or maybe you have not properly scanned the ECG. It may be infralateral MI. Is it clear? So elevation followed by T wave inversion happen in only one condition, that is infarct, ischemic injury. But if it is an inflammation, third is the PR segment that will be getting means ST elevation is there, PR segment depression is there. So the PR segment depression, ST elevation, and there's a final sign on which we call it a spodiac sign, that is the uh, TP segment will start downsloping. So these are the three important signs of pericarditis. Okay, clear? Regarding the ST elevations, so concave, convex, this thing, I think what I was telling you, whenever you are getting ST elevations, the T wave should not invert. If the T wave, see here, the T wave has inverted. That's why it is convex. This is called convexity. Here you can see the T wave is positive. This is concave. So convex versus concave, the meaning is only one thing. When the T wave is inverted, it is convex. If the T wave is positive, it is concave. So concave, a lot of condition can happen. Early repolarization, pericarditis, baseline abnormality, everything will be there. But in elevation, if T wave is inverted, until proved otherwise, it is infarct. So if who I have seen the myocardial infarction, they will say, "Oh, you are already having heart attack." They will not ask any question. When I see this ECG, I will say, "You are having infarct. When was the pain?" You will say, "No, no pain. Anytime gastric, 10 days back I was having. Any sweating was some sweating was there." So by seeing this ECG, you can dig out the whole information that he was having infarct and when it was there. He may not having the pain right now, but he was having infarct, and those ST elevations are there. Okay. So ST flattening also, it is one of the important sign of elevation, depression, and after that flattening. So if three segment, sorry, here you can see the part of the ST will start going up, but sometime the ST three small boxes, if it is flat, hugging the horizontal line, it means it is flattening, and this is a sign of ischemia. So you are getting lead V4 to V6 ST flattening. Don't expect that you will be getting T wave inversion, you will be getting ST elevation, you can be getting ST depression. It may be ST flattening with chest pain of angina chest pain is enough to make a diagnosis that he is having a resting angina, which is an unstable angina versus non-ST elevation MI. Okay. So there are three type of what you call ST depressions. One is the upsloping, which is taken somewhat lightly, means it is not always a ischemic finding. But downsloping and horizontal ST depressions are always a finding of ischemia. So whenever the person is going for treadmill test, upsloping ST depression has been noticed, they are mildly positive or somebody whether it is negative. But whenever this is happening, one is the downsloping ST or horizontal ST depression. And again, the rule you have to apply consecutive leads, not one lead. One or two leads should be positive. Then you are going to say the patient is having ischemia. Whatever the rule ST elevations when we are using, it is applicable for the anterior, inferior. But one of the territory, the posterior, we call as the posterior side of the heart, it always break all the rules. Okay. And if you're appearing in the examination, they will say there is no elevation, why you are saying infarct. So here the rules are totally different. And the rules are, number one, depression in the anterior lead. V2, V3 lead, if you are getting ST depression, it is a mark of ST elevation in V7, V8 lead. Okay. Second is R wave. Usually Q wave is taken as a mark of old infarct. But if you are getting upright V2 or V1 lead, you can say the patient is having posterior infarct, particularly V2 leads. So here a positive R wave. Lead V2, we are not expecting any Q waves. If Q wave is there, means it is an infarct, enteroceptal infarct. If it is getting a totally a R wave, it is a posterior infarct. Clear? Because it is a reflection of the posterior heart. So the same Q you are getting in the, but here what you have to apply, if it is broad, then only. If it is a narrow, again the rules will be different. Okay, and 0.5 millimeter in the posterior leads. Okay, and usually we use the ST elevation and depression more than 1 millimeter or 2 millimeters. So last time I forget to tell the V2 V3 lead up to 2.5 millimeter ST elevations may be there, and that's why the baseline is very important. Always see what is the baseline heart rate when the ST elevations or segments was there. Okay. Okay. So here, what type of MI it is? What MI it is? Where the MI is? MI or not? Hmm? It is basically ST elevation MI only, but it is posterior. So whenever you are getting V2, V3 leads ST depression, immediately go and see V7, V8 lead also. You will get ST elevations. So this is a depression or reciprocal changes of the posterior side of the heart. So depression coming here is a mark of infarct. Usually elevation we always take, but in depression is not a terrifying. And this is the thing I was saying that whenever you are getting a concave, it is a infarct, and depression, the same thing means depression is a finding of inverted T wave with the elevation. So whatever you are saying, it is ST depression, pathological R wave is the pathological Q wave, and T wave is upright, it is inverted. So these all things will favor, and I think uh, yeah. So you can see in this one, ECG you have to make it inverted, and after that you will start seeing the pattern. You will get the proper ST elevations. Okay, you can get the ST elevations. Chalo. So sometime patient has come to you and you have having typical chest pain. Even I have also missed some of the cases during my residency also, and it is important that sometime the reciprocal changes will be coming early, or some elevation is there in one lead and you have just seen that lead and say, okay, everything is fine. And that's why I say clinical history is very important in background of the risk factor. If a patient is diabetic, I will say, okay, diabetic, okay, repeat the ECG. One ECG is normal, second is normal, third is normal, it's okay. Most of the time, ischemia over 2 hours with a angina chest pain is not there, less likely to be. Angina chest pain is important. You have to admit the patient with a diagnosis of unstable angina if property is negative, positive, non-ST elevation MI. Okay. But elevation, this pi L, if the patient is having posterior infarction, elevations will be, depressions will be, means ST depression is what we call as the reciprocal changes. So where to see the reciprocal changes if the patient is having infarct? Posterior, it is anterior. Where will be? V2, V3 lead. If it is anterior, where we are going to see? Inferior leads. And if it is inferior, where to see it? Lateral leads. So patient is having some ST elevation only in one of the lead. What you are going to immediately start seeing the lateral leads. So C1 and AVL. So first sign of inferior wall infarct may be ST depression in V5, V6 lead or 1 and AVL. Is it clear? So when you are getting a ST depression, repeat the ECG after some time. Because if you are repeating the ECG, you may be able to see the ST elevation, and you are right now in care, you are having all the opportunity to push the patient in the cath lab and get the what you call primary PTC can be done. But if you are in the periphery where you have to thrombolize the patient, and the thrombolysis is given in the patients who are having only and only ST elevations. So ST elevation you have to label it, ST elevation you have to show, and ST elevation how you are going to say. You have seen non-ST elevation and my ST depressions are there. And morning you are when you are getting up, you are seeing ST elevation has come in inferior lead. Why? Because you have not seen the repeated the ECG after some time. The patient was having chest pain, you have given heparin, you have slept, and if patient died due to any reason in the morning, you are in the soup. Why the patient was not thrombolized? And it's a difficult question for anybody who's practicing medicine. So to avoid all those things, try to bank on ECG, repeat the ECGs. Whenever you are in doubt, repeat the ECG. It will give some insight. And if it is an ongoing ischemia, it will never ever be same. Media, they are saying ECG will be normal, patient will be having block. There's a totally different story. I'm saying ongoing angina, ECG will never remain silent for a long time. It will pause it. It will start showing the sign. It may show tachycardia, it may show ST depression, it may show upsloping, downsloping, flattening, anything will come. But your eyes should be eager to watch for those changes. Otherwise, you will miss it. Okay. Now coming to the T waves. बहुत ज़्यादा पका दिया लगता है. Okay, so T wave is one of the most wave which are neglected also and too much interpreted also. So T wave changes with the QRS. So when QRS changes, it is most of the time it will follow the same, because last time I told the repolarization and depolarization are in the opposite direction. And whenever the bundle branch block is happening or repolarization abnormality is happening, the T wave will go in the opposite. LBB, positive QRS, T wave will be inverted. This is the normal thing. If it become positive, it is a sign of ischemia. Okay? So when the patient is in sinus, QRS is narrow, T wave should be in the same direction with the QRS, in the limb leads at least. But when the bundle branch block, you are writing the diagnosis, the T wave will be opposite to the QRS. RSR pattern, last is R, so T will be negative. Is it clear? And some changes that peak T wave, hyperacute, inverted, and biphasics, these are some important concepts. Let me touch those points also. So T wave inversion in the lead 3 is the normal. So don't expect a lot of time I get a call that's a T wave inverted in lead 3. So lead 3 is having normally also you will get some Q wave you will get normally in the lead 3. Lead 3 is not the axis on lead 3 is one of the lead in which you will get all the abnormal waves normally present. Q waves, T wave inversions, RS patterns. So these all things will be normal in this lead. New T wave inversion, that's why old ECG is very important. New T wave inversion is a mark of ischemia. So when it is happening, you have to give attention, and if the patient is getting chest pain, it is important. T wave inversion is usually symmetrical and deep. Whenever it is happening, it is mark of ischemia or CVA TVA pattern. Means anything has happened, infarct in the brain. Heart will also show the signs of ischemia in the ECGs. Juvenile T wave pattern. So from 7 year to 7 day to 7 year, T wave will be mostly inverted in a baby. T wave will be positive when the baby is born. Within 7 days, it will get inverted from V1 to V3 leads. Okay. So we get juvenile means when the person is baby, means when he is not in the adult, the T wave will be negative in V1 to V3 lead. This is called normal T wave pattern. But the person is grown up like me and I am having V1 to V3 T wave inversion, then I will say juvenile. Abhi bhi bacha hai. His ECG is still showing the same juvenile pattern. So that's why V1 to V3 leads sometimes disguises ischemia also. If you are not aware whether it is a juvenile T wave pattern versus it is a ischemia, then it becomes difficult. So ongoing chest pain, T wave inversion, V1 to V3. What you are going to enterolateral ischemia? Is it possible or not? So that's why baseline ECG is important. Morphology of T wave become important. And what morphology you are going to look for that? Symmetry. So if it is becoming symmetry, both the T waves are having the same. It is becoming more deep, more than 3 millimeters. That's why I'm saying New T wave inversion. Pathological T wave means it has inverted and it is deep and symmetry. Symmetricity of the T wave is not expected. This is one of the asymmetrical wave. Rest all things you can think about P wave up and down is same. QRS we are knowing that is a depolarization. The three waves will maybe there, but T wave is asymmetrical. Symmetricity means patient is having ischemia. Okay, T wave is inverting, which was positive. Again, some injury is happening or some ischemia is ongoing. And left and right ventricular overload, also the typical patterns will be there. So this thing I just wanted V1 to V3 up to 7-day upright T wave means if a baby is born and T wave is inverted in V1 lead, it is a mark of लिखा हुआ है ना. Normally it will be upright because usually right ventricle is dominating. It should get inverted over the 7 years. So the changes is started happening from right side to left side. And the juvenile T wave, three important thing. Number one, asymmetrical. Second thing, shallow, less than 3 millimeter, and limited to V1 to V3 leads only. Don't try to explore other than V3. This is, please come. So T wave inversion is the important one of the findings, and this important is the valence sign. Again, we are going to see in the same leads V1 to V3, and there are two patterns. The T wave may be bifid, means positive negative, and T wave will be totally negative and symmetrical. So when you are getting a valence, means the patient is coming without pain, and you have seen this ECG. You can give the report of angiography by seeing this ECG. You are having LAD block around 80 to 90%. And the patient is saying, no, I am not having anything. And you do the angiography and you can show the magic, see it is blocked. And this is the beauty of ECG. You have decided because the patient was not saying that he was having 3 days back chest pain. You asked any time within 1 week you are having chest pain. I was having some pain, now I am not having. But this pattern is enough to label the artery which is blocked. Okay. So if you are getting this pattern, we call as a bifid T wave, means positive negative in V1 to V3 lead, or totally symmetrical T wave which is more than 3 millimeters, pathological T wave inverted, which you got around 75% of patient, you can label the artery which is blocked, LAD. Okay, means somebody has done a lot of work to identify this thing. We are just utilizing his skills. Okay, and there is one more important sign is D Winter syndrome. So in D Winter, again the ST, what we are seeing elevations, in place of ST elevation, you will be getting ST depression, particularly in the V1 to V3 leads. So if we are getting ST depression, in particular V3 lead, it is also a mark of ischemia. And here again, the artery of culprit artery is LAD. Okay. So tall, prominent symmetrical T wave in the precordial lead, upsloping ST depression more than 1 millimeter, absence of ST elevation in any precordial leads means you are getting ST depression, and ST segment elevation in 0.5 to 1 millimeter if you are getting AVR. So these are signs, and here this valence as well as D Winter syndrome, both are, the patient will come without chest pain. Okay, so patient is having some events in the past, but he is coming right now and he's having just as a mark that okay, I want to get my cardiac checkup, and you are getting this type. Either one is on the T wave. What is the T wave? Bifid, mean positive, negative, or totally negative symmetrical waves in V1 to V3, or you are getting ST depressions with upsloping, that are also the finding in the precordial leads. So both are finding of LAD blocks. Hyperacute changes, one is hyperkalemia and second is hyperacute myocardial infarction, the first changes of myocardial infarction. So what is the basic difference between these two things? Huh? Patient is having hyperkalemia. Patient is having myocardial infarction. Early myocardial, we call it hyperacuity. How you are going to differentiate it? Hmm? QRS. No, we have to see by the morphology of the T wave. Huh? No, T wave inversion, that will happen after the infarct. I'm saying the patient is coming chest pain. You are thinking probably he is having infarct versus hyperkalemia. How you want to differentiate it? Tall, tented, very good. But the important thing, always try to see the base. Narrow base and peaked. नीचे का जितना पतला रहता है and peaking means you can see the peaking here. This you will get only and only in hyperacute, hyperkalemic changes. Okay, and it is becoming broader when the patient is having ischemia, because ST and T wave both will be playing during the ischemia. But when we are having a patient is having hyperkalemia, the ST segment is not getting anywhere in the whole story. It is only the T waves, T wave, QRS broadening, P wave loss, all these things. If you really want to remember the hyperkalemia, just put a finger on your T wave and start pulling it. What will happen? Peaked, narrow, QRS widening, loss of P wave, sinusoidal pattern. So these are the four stages of the hyperkalemia which will be happening. But in ischemia, the summit of the QRS T wave will not be peaked. It will be broad. Base will be broad. ST segment will be getting elevated. Okay. I think all these things, and what I was saying, dynamic versus fixed changes. So whenever the dynamic changes are happening, T wave was V2, V3. Later on, it is going V5, V6. It was more negative now. Like that, if it is happening, it is taken as more grave than a fixed T wave inversions. Okay. So always look for the dynamic changes over the time how it is behaving. Now, the last regarding the Q waves, the abnormal waves means when we are going to see what is the pathological Q waves, delta wave, epsilon, and Osborn wave. In India, I don't think if you are living in this part of the country, we are going to look for the Osborn. Otherwise, because this is in the very cold places where the cold injury has happened in those type of situation. Delta, epsilon, and Q waves. Q wave you will be getting most of the time. Where the Q wave is a normal, one lead, where it will be always present. AVR lead. It will be always QS. We can use the word QS, but it will be always present in that lead. Epsilon and delta. Delta means pre-excitation. Epsilon means post-excitation. So one will be before the QRS, other will be after the QRS. And how to look for it. So first is pathological Q waves. So what are the pathological Q waves? The Q wave which is more than 40 milliseconds and it is white means one small box above. 25 millimeter of depth means QRS is 20, then it is more than 5 millimeter. If you are getting the Q waves, it is again pathological. And third, it is seen in V1 to V3 leads. V1 is somewhat spared, but V2, V3, we are not expecting any time the Q wave. If it is coming, it is a pathological, means patient is already having infarct. So broadening as well as depth, both you should see. Broadening, more than one small box, and depth, more than 25 of the consecutive R wave. If R wave is 20, it should not cross more than 5 millimeters. 25% of the consecutive R wave. Coming to the delta waves, so it is the initial slurring of the QRS. So after P, if you are getting a short PR interval, and after that you are getting some sort of, let me escape it, yeah. So whenever you are getting a short PR interval, immediately start, means your reflexes should be short PR means what can be, whether I am missing the delta wave or not. And delta will may not be there in all the leads. Some lead it will be very prominent, some lead it may not be prominent. So you have to see all this, you have to scan all the leads. And again the consecutive leads comes. If you are seeing the inferior, it will be in inferior, it may be anterior also, it may be lateral also, depending on where it is, the pathway we are going to decide it. Okay. So you can see the delta waves, and these delta waves, if you are in emergency, sometimes you will say patient is having infarct because the ECG If the machine is not able to pick up the short PR interval, it will give infarct also. And what are the infarct you can see? Anterior infarct if the negative delta wave you are seeing in the precordial lead, V1 and V2. Anteroseptal MI, it will write, old anteroseptal. If you are getting a negative delta wave in AVL, which may be a part of one of the pathway, it will give a lateral wall MI. Inferior wall MI if there is a posteroseptal pathway. And if the posterior means if you are getting a right bundle branch type of pattern, it will give that the patient is having RBB or it may be saying a posterior MI. So these all pattern will be possible if you have missed to see the delta wave, and sometimes the delta wave may be preceded with a short PR and you have not picked up. That's why systematic approach is very important. When I was doing my DM, I have gone to my uh, guide and saying, sir, patient is having inferior MI, can we do the angiography? I'm like, angiography, why? He's having postoceptal pathway. And that time I scratched my head, okay, why I means I feel so sorry that I was doing DM and I have not seen the delta wave, because we are so much inclined to the ST segment Q waves. We never give that much attention to the patient came not with the pain also. He came just palpitation and some here and there atypical chest pain. We see the ECG and immediately, okay, Q waves are there. In fact, because we are so much ingrained to get angiography done, because in that time that is your bread and butter. We want to learn that angiography. So this patient is angiography candidate. Let us take to the cath lab. And he saw that he is having infarct, and that time I feel very sorry for myself that systematic approach we should never. So clear cut Q waves was there, and we thought patient is having infarct and patient was having WPW. So So these two words earlier being used, that is called type A WPW and type B WPW. A means left side, B means right sided, and B is very common in which type of which type of congenital heart disease? Anybody can say? One disease in which the pathway mostly will be there. Congenital heart disease. Hmm? Epstein anomaly. Epstein anomaly, if you are not getting pathways, there is a saying that if you are getting a right bundle branch block in a patient of Epstein anomaly, until proved otherwise, the patient is having pathway. Like that it is. So A means left side versus right side. You have to decide. To only go and see only one lead, V1 lead. If it is positive, left sided pathway. If it is negative, right sided pathway. At this time, you should know this thing. After that, we can decipher whether it is in posterior, lateral, anterior, anteroseptal, right, lateral. All those things we can decide by seeing the ECG. And there is some permutation combination of the rules of delta and Q waves. All those things we use. The second information where you can get pseudo delta waves, that also you should remember. So some VTs will be giving, means the VT will be ventricular tachycardia. You will be getting slurring of the QRS, and those slurrings are very common in the ventricular tachycardia originating from the epicardium. It is not a matter of discussion here, but you should know where you can get some delta waves like scenario, but still the patient is not having WPW. So VT will be having epicardial AVT. And delta waves, okay. An Osborne wave is nothing, is a prominent J wave with elevation, nothing else. That is called Osborne wave. Epsilon wave. So some patient will be having like delta wave is, we call it a pre-excitation. So something which is happening after QRS will be called as a epsilon. Delta D followed by E. Epsilon where it will be after QRS. So this pattern you are going to see where after QRS. Which lead we have to see? That book will not be writing. So you have to see in the V1 to V3 leads. In electrophysiology, most of the information comes from to V1 to V3 leads. And most of the noise means all the misinformations, the early juvenile T wave pattern, ST elevation of more than 2.5, all these misreadings happen of V1 to V3. So V1 to V3 is a very difficult, what you call lead for giving the final interpretation if you are not knowing the background. If patient is having pain and you are getting 2 millimeter ST elevation, you are still in doubt. You have to repeat the ECG. And then your elevation is going up, ischemia. Not going up, it may be a early repolarization. Like that, you have to make it. So V1 to V3, be careful. These leads always disguise for arrhythmia or ischemia. Okay. So some changes are there. Be complacent. Watch the old ECGs, how it is, and then you should make an interpretation. Give some time. Repeat the ECG if you are in doubt. You will get some lead. If still you are in doubt, then certainly you are having drop T, CPKMB, all those things. But never neglect V1 to V3 leads. So what we will be getting here, this is one of the disease. This epsilon wave is a story of one disease we call as a arrhythmogenic right ventricular dysplasia. This is one of the commonest cause of death in Italy in the athletes. So athlete death, whenever it is happening all over the world, there are two important causes. If it is under 20, we call it as channelopathies. If it is happening under 40s, we say channelopathies and cardiomyopathy. If it is happening more than 40 years, the chances of what you call coronary artery disease will be high. So when we are taking whole information all over the globe, it has been found that particular countries like Italy and that European country, the cause of death is more from the ARVD, arrhythmogenic right ventricular dysplasia. This is one of the disease. Even I think general medicine you may not be have been taught so deeply. So in this, the ventricle has been the muscles of the right ventricle is been replaced by the fat tissue. So whole right ventricle muscle is changed with the fat. So the changes will start happening, and these patients presents with the VTVF collapse. When they will be playing, all of a sudden VTVF will happen. They will collapse. CPR done later on come. If it is in early stages, you may not be getting the clear-cut echo finding also. Sometimes we have to do the cardiac MRI to get the full diagnosis. So athlete death or exercise induced VTVF or cardiac arrest it is happening. This is one of the important differential diagnoses other than long QT and CPVT. These are the two conditions in which the patient can collapse during the exercise or during just after the exercise. So long QT syndrome, CPVT means catecholamic polymorphic VT, and third is arrhythmogenic right ventricular dysplasia, and the most common genetical disease of the heart, hypertrophic cardiomyopathy (HCM). So these are the four conditions in which the exercise-induced collapse happen. So in this, there is local QRS widening. Local QRS widening. Word I mean, when we are discussing, we are saying QRS widening, narrow versus QRS. But here there is a local QRS widening will happen in a particular leads, and these leads are V1 to V3 leads. So you will be getting the QRS in the form of the, here you can see wiggle. We use the word wiggle. Here you are getting some slurring. So this slurring is taken as a finding of epsilon. So this is epsilon. It may be a small p like. P is a somewhat wider. It will be somewhat smaller than that. So this wiggle, when you are getting at the terminal part of the QRS, will be taken as a epsilon wave. So first you should know the disease, suspect the disease. After that you have to see the QRS has having a different, means some are showing a localized widening, and this widening is present in the V1 to V3 lead. Then you have to start seeing whether you are getting epsilon. Some QRS widening you are getting and you are not having a typical pattern, then certainly the diagnosis is incomplete. And this leads V1 to V3 lead is one for the ARVD and second for the sudden cardiac death. One more condition we call as Brugada syndrome. So these two conditions, there the ST elevation will be coming in a patient who is having 25, 35 years, under 35 years. So there will be a ST elevation T wave inversion, no chest pain, but collapse. So again, that is one of the conditions. That's why V1 to V3 leads, we have to be careful while making the diagnosis. So this is the pattern you can see. Arrhythmia, this is a fat tissue which is encroaching on the muscles. So whole muscles of the right ventricle will be going to be changed by the fat tissue. And this will be reflecting here, the QRS will start, the current will be reducing. Over the time, the amplitude of the QRS will be start reducing. It will be in the more in the chest leads, and there is some electrical injury we call as a injury will be happening, and that will be reflecting as the epsilon wave. Okay. So those will be coming, I think. And this was, I was saying, the patient V1, V2. So you can see the ST elevations here somewhat, particularly in one lead only, V1 and V2, and T wave inversion. So this we get in the condition patient is coming with a collapse, VT, VF, or sudden cardiac arrest, resuscitated. If you are getting, it is a sign of Brugada syndrome. So this is also a arrhythmic disease. And finally, we have to make a impression. And what is the impression? Normal study. Within normal means abnormal, normal, what we call as. And patient may be having infarct, ischemia, whatever pre-excitation, whatever you are getting, you have to make a conclusion. So thank you so much. I think we have completed all the ECG. What I am thinking, it is the basic. Second part come regarding the arrhythmias. If you are interested, we will start. But after the lunch or yeah, breakfast, आया कि नहीं अभी तक? After breakfast, we can again meet. If you are having any question, query, you can ask right now. Or you all are hungry right now. Huh? Hmm?